Welcome to the Lymphoma Research Foundation's Update on Oral Therapies in Lymphoma and CLL webinar. I'm Natasha, and I'll be your operator for today's call. During today's call, you will hear from an expert speaker, and you will have the opportunity to ask questions. If you have questions during the presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you are listening by phone, the link will be sent to you by email at the end of the webinar. And now I'm pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you. And thank you to each of you for taking the time to join us in today's Update on Oral Therapies in Lymphoma and CLL webinar. We'd like to thank our sponsors of this webinar, Karyopharm Therapeutics and Pharmacyclics, an AbbVie company, and Janssen Biotech. Before I turn the program over to our speaker, I want to briefly share information with you on the Lymphoma Research Foundation. Access to expert disease information is so important, and we are thrilled to be able to bring you this education program today. LRF is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on the phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options in clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have similar experiences to help give others strength to meet the challenges they may have to face. We also offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. We have comprehensive books on understanding NHL, HL, CLL, and the transplantation process. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content as well as unique tools to help manage your disease. The app is available for free download in the Apple App Store and in Google Play, and I encourage you all to download the app today. Finally, we've launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. Please visit our Learning Center for access to webinars, articles, and other resources specific to COVID-19. I really hope you'll take advantage of some of the great resources and services that LRF provides. If you have questions regarding what you learned today, or if you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Jonathan Cohen. Dr. Cohen is the co-director of the Lymphoma Program, medical director of infusion services, and a chair of the Data and Safety Monitoring Committee at the Winship Cancer Institute of Emory University. In addition, he is an associate professor in the Department of Hematology and Medical Oncology at Emory. Also, he has served as an expert speaker on numerous LRF patient programs in the past. Thank you for speaking at our program today, Dr. Cohen. I'll now turn the talk over to you.
Great. Thanks so much, Jessie, and to the entire LRF team. And before I dive into the talk, I just want to take a moment as a physician that cares for patients with lymphoma and CLL, just to highlight the incredible resources provided by the LRF. They have so many resources available that have helped my patients, both from financial support, educational support, and also supporting important research that's being done. So I do encourage each of you that aren't already familiar with the website and the app to take a look, as it has certainly made a big difference for my own patients. So today I'll be tackling the topic of oral therapies in lymphoma and CLL. And these are my disclosures, which are primarily related to the research work that I do in CLL and lymphoma. And I want to start with a warning, and I think that this is probably maybe the most important slide, is that this is not a comprehensive review. So the LRF, for example, has already put together in the past day-long symposia looking at optimizing oral therapies in patients with lymphoma and CLL. And to try to condense this into a 35, 45-minute session and allow some time for questions, necessarily I've had to really hit some of the highlights. So please recognize that this is not comprehensive and that this talk doesn't necessarily apply to each situation, but I'm going to do my best to address some of the common scenarios where we use oral therapies and some of the overarching themes. To that end, it is always important to consult your treating oncologist regarding whether a particular therapy is appropriate for your case. And so we may discuss a particular oral agent today that may seem appealing, but it may be that for your particular case, it's not appropriate, or maybe there's a better alternative. So be sure to have a conversation with your oncologist. It's also important to remember that many oral therapies, including those I'm speaking about today and otherwise, are being investigated in ongoing clinical trials. And so while it may or may not be approved right now for use outside of the setting of a study, there at our center at Emory and really nationwide, there are a number of opportunities to look into clinical trials using some new oral therapies. And then finally, I just want to point out that off-label use of oral therapies may be appropriate for you, but again, this should be done in consultation with your oncologist and in consideration of your particular case. So I know that those are sorts of disclaimers are commonly seen, but I think it's especially important for this particular topic just because it is such a broad area and because this is a field that's continuing to grow. So we'll talk about some of the general considerations for lymphoma treatments just to sort of set the stage for where oral therapies fit. I'll go over some common myths that at least I've addressed with some of my own patients. I will talk about some disease-specific indications and drug toxicities, but I think, again, it's important to recognize that we can't possibly go over every individual therapy during this talk, but I'll try to hit, again, some of the more commonly used agents. And then finally, I'll end with some talking points and some other questions to consider and some things that I'm looking forward to in the future. So this is, again, a broad slide looking at the number of different management options we have in lymphoma and CLL. And for many of you, especially with a low-grade lymphoma or with CLL, the top one may be where you are right now. So perhaps you have disease that has fortunately not caused a lot of symptoms and for which you're currently engaged in a program of watchful waiting and maybe logged in today to learn a little bit about what may be in store down the road. But this is a very common approach for patients that have what we call a low tumor burden or otherwise asymptomatic disease. Traditionally, we've used chemotherapy, especially for aggressive lymphomas, and this is what often people think about when they think about cancer treatment. So these are usually intravenous treatments. They tend to be associated with some of the more commonly recognized side effects like nausea and vomiting, low blood counts, hair loss, things like that. And we still do use chemotherapy frequently in lymphoma, especially in the aggressive lymphomas. There are a number of immunotherapies that are out there, and these are therapies that either use your own immune system or where immune cells are injected into your body in an attempt to take out the cancer. And you can see there's at least 4 different classes of drugs, and of course this is beyond the scope of today's talk, but again, a very exciting new area in the management of lymphoma and CLL. Radiation therapy and radioimmunotherapy are also commonly utilized therapies, more often in the relapse setting, but certainly there can be a role, especially for radiation in patients who have a limited stage disease or who have or who may not be great candidates for chemotherapy. And then finally, the oral therapies. And I just want to, I think this is an important slide because it highlights the fact that in 2021, we have a large number of ways to treat lymphoma and CLL. And it continues to change over time, and it's important to recognize that oral therapies is one such method that we have to treat these diseases. So, just thinking about the pros and cons. So, I remember during my training and even prior to getting into medicine, always thinking about how great it would be if we just had a pill. So, if you had cancer, you would have a pill that you could take, and that would be all we would need to do. And in many ways, you know, for many of these agents, that really has changed the way we think about treating cancer. But it's important to recognize that there are both pros and cons. So the main pro is that it's much more convenient. You have a pill bottle in your bathroom. You take it every evening or every morning or twice a day, and that's it. So you're not having to go to the infusion center and sit all day getting an IV infusion. You don't necessarily have to have a port or any other special IV lines. And so from that standpoint, it clearly has changed the way patients live their life. And certainly it makes things like travel and work scheduling easier. So patients on oral therapies often can go on trips, can without having to worry about when their chemo is due. They can work, and so from that standpoint, it is an improvement. And often we've seen that some of these may have less severe toxicity than more conventional chemotherapy. And I'll go over some of the studies that suggest that it actually may be more effective. And then finally, in many cases, you're continuously treating the cancer. And a lot of my patients really like the fact that when they're on an oral therapy, they feel like they're continuing to treat the cancer over a long period of time. Now, the cons can also be significant. So adherence can be difficult. So, for those of you that may have other medications that you take, you recognize that remembering to take a medicine every day can be difficult. And I take an allergy medication, and I can tell you that at least a couple times a month I forget to take it. I get busy in the morning and forget to take it. And certainly if you're feeling well and doing well, it's easy to sometimes forget. Also, these can be costly medications, and there can be hassle with obtaining it. So if you have to work through your insurance company or potentially do some financial assistance, that can take some time and can require documentation. In addition, and this is something I think that we're learning more and more about as we go, there are chronic low-grade toxicities. And so when we think about clinical trials, we often will assign a grade to a side effect, ranging from 1 being a very mild toxicity all the way to a grade 5, which is a toxicity that results in a patient's death. And so we often think about toxicities that are grade 3, 4, or 5 as being the more severe toxicities. Those are the ones that might result in a patient having to go in the hospital, for example, or require urgent medical attention. But grade 1 and grade 2 toxicities, while not life-threatening, can certainly be life-altering. And so I often give my patients the example of grade 1 or grade 2 nausea, or grade 1 or grade 2 diarrhea. These may not necessarily be life-threatening, but if you're living your life with, having, an episode or two of nausea each day, and you're not always sure when that's going to pop up, that can be problematic. And again, many people are willing to endure some side effects for 6 months on chemo because they know that it's going to be over. But if you're talking about being on therapy indefinitely and just causing some mild nausea symptoms, day in and day out, that can be a problem, even if it's not necessarily life-threatening. And similarly, some of these agents can cause late or unexpected side effects, so things that you may not have been on the lookout for that could develop a year or even longer into treatment. And then finally, there can be interactions with other medications, and that's something else that's very important and is not always fully appreciated when we are getting ready to start a therapy, and that's where collaboration with a pharmacist is critical. So there are a couple of oral therapy myths that I want to highlight. The first is that since oral therapy is not, quote, chemo, it's less toxic than chemotherapy. And I think what I like to stress with patients is that these toxicities can be different. So you may not necessarily have as much nausea or vomiting. You may not lose your hair. You may not require blood or platelet transfusions, but there can be other toxicities that can develop that can be pretty severe. So for example, with the BTK inhibitors, we know that sometimes there can be atrial fibrillation, which is a heart arrhythmia that can be a problem. There can be bleeding complications. And so it still is important to recognize that these are anti-cancer therapies and that they can certainly have side effects. And so it's important to have an ongoing relationship with your oncologist as you're on treatment to make sure that any side effects that arise are managed appropriately. I've had some patients that are concerned that when we recommend an oral therapy, that because it's not as intense or because it's not the more traditional chemotherapy, that it may be less effective. And in fact, there have been a number of studies that have shown that in some instances, oral therapies have proven to be more effective than traditional chemotherapy. And so some of the areas where we've seen this emerge the most has been in CLL, or chronic lymphocytic leukemia, where a number of studies have suggested that treating patients with oral therapies as their first line of therapy is likely a more effective approach than traditional chemotherapy. Another myth is that oral therapies are safer and that they're not associated with a risk of infection. And this is unfortunately just not the case. And so we've seen several severe infections that have been described with a number of our oral therapies. And these are often infections that are a little bit unique, that are different than sort of a traditional urinary tract infection or pneumonia. Sometimes there's very unusual forms of pneumonia that we can see, or other what we call opportunistic infections that can sometimes arise. And so again, this is something that's important to keep in mind. It's not meant to be alarmist, but just to recognize that these are treatments that can still have complications. And then the last is that oral therapies are prohibitively expensive for patients. And it is no secret that many of the oral therapies that we prescribe are very expensive. And if a patient was in a position where they would need to pay out of pocket the full cost, most patients would not be able to manage that. Fortunately, many of these, if not all, are associated, are covered. I'm sorry, most of these are covered by most insurance plans. And then even when you have a copayment that is particularly high, the different pharmaceutical companies have done a fantastic job of helping develop some patient assistance programs to help those patients who can't afford their copay. And then there are often other resources available. The most important thing, though, that you can do is to discuss this with your oncologist. And I know that this can sometimes be not the discussion that you want to have. You know, you have a meeting with your oncologist, and he or she feels that a particular agent is the right one for you and goes to order it for you, and you may not want to speak up at that moment and say, well, wait a minute, I don't know if I can afford it. But it's important to have that conversation because, like I said, there are a number of resources available to be able to help obtain this at a reasonable cost. And so, again, don't decline a therapy without at least trying to see what you can work out, because in almost every case, we're able to work something out that is manageable. So there are a number of types of oral therapies. So there are some that are more conventional chemotherapies like chlorambucil, which are just administered orally. You can see that there's the immunomodulators, and then there's other targeted therapies. And as I mentioned before, this is not an exhaustive list. So, for example, after putting this together, I realized that, for example, I had left off the EZH2 inhibitor tazemetostat, which was recently approved for follicular lymphoma. We just had a recent approval just this past week of Ibrutinib, which is approved now for follicular lymphoma and marginal zone lymphoma. And so, again, the key here is not for this to be an exhaustive list, but just to recognize that there are a number of therapies out there, and there are a number of therapies that are not currently approved, but may be in the near future and that are under investigation. And they work in a variety of different ways. So the question that many of you, if you're enrolled in today's webinar, are wondering, well, is an oral therapy appropriate for me? And so in a number of diseases, we are very, very commonly using oral agents. So CLL or SLL, almost always now we use an oral therapy, especially in the untreated setting and even in the relapse setting. For many of our indolent non-Hodgkin lymphomas, there's a number of oral therapies that are available. In mantle cell lymphoma, it's the same. And then in some aggressive non-Hodgkin lymphomas, including large cell lymphoma, we often use oral therapies. So selinexor was recently approved for aggressive lymphoma, and lenalidomide is approved in combination with a CD19-directed antibody called tafasitamab in patients with relapsed large cell lymphoma. And then there are others that are out there. So again, this is becoming ubiquitous throughout the different lymphoma subtypes and throughout the different stages of lymphoma treatment. For Hodgkin lymphoma, for Burkitt lymphoma, and for most T-cell lymphomas, oral therapies are not utilized quite as frequently. There are some exceptions, especially for the T-cell lymphomas. And so I think, again, it's important just to have a conversation with your oncologist about what's appropriate. And even if a therapy isn't necessarily indicated, again, there may be there may be a reason to use something in an off-label setting, and then there also may be good clinical trial options to consider. So next I'm going to talk a little bit about some of the specific agents and some of the data that supports their use. And this is, again, not meant to be exhaustive. These are not meant to be, formal presentations of the data, but just to sort of provide some highlights for why we recommend some of the therapies that we do. And so in CLL, as I mentioned before, oral therapies have probably emerged most prominently as the treatment of choice. And there were two large studies that were conducted and that were presented, as you can see here now, a couple of years ago, comparing traditional chemotherapy with Ibrutinib, which is a BTK inhibitor for patients with untreated CLL. And there were two studies that were presented. One was for younger patients, and this compared rituximab plus Ibrutinib with the FCR regimen, which was a traditional intensive regimen that was utilized in CLL, and that's depicted here on the bottom of the slide. And on the top of the slide is the study that was developed by the Alliance Cooperative Group that evaluated bendamustine rituximab versus ibrutinib-containing regimens, and this was for older patients. And what you can see in the Kaplan-Meier curves here on the side is that the ibrutinib-containing regimens outperformed the chemotherapy-containing regimens with regards to progression-free survival. And for those of you that may not be familiar with this type of a curve, these are called Kaplan-Meier curves. And all patients start out at time 0 up at the top, which is at 100, meaning that 100% of patients are free of disease progression when they go on to the study. And then patients are followed, and when patients have a progression event, the curve goes down. And so the higher the curve is, the fewer progression events that you've had. And so if you look at the top curve, you can see that the dotted line, which was rituximab plus ibrutinib, and the solid line, which was ibrutinib alone, are both higher than the curve that shows bendamustine plus rituximab. And this suggests that those patients that received ibrutinib were less likely to progress or pass away over the course of the treatment. And so you can see, for example, it goes out to 48 months. So that means within those 4 years, by 4 years out from starting therapy, you can see that fewer patients who received ibrutinib had progressed compared to those patients who received bendamustine and rituximab. And if you look at the curve on the bottom, you can see that the red curve and the gray curve separate in a similar fashion. And for these reasons, it was concluded from these studies that administration of ibrutinib is superior to chemotherapy in most cases for CLL. In addition to ibrutinib, we have an additional oral therapy that's now been approved called acalabrutinib. This is also a BTK inhibitor, and this is administered twice daily instead of once daily. And this is a separate study that was conducted in primarily older patients with CLL or those that had other medical conditions. And patients were assigned to receive either obinutuzumab, which is a CD20 antibody similar to rituximab, plus acalabrutinib, acalabrutinib alone, or obinutuzumab plus chlorambucil, which, as I mentioned before, is an oral chemotherapy that's been approved for use, especially in older patients with CLL or those that have medical comorbidities. And this Kaplan-Meier curve is set up just like the other ones were that I just showed you. And again, you can see that those patients, those groups who received acalabrutinib, whether it was in combination or by itself, had a superior progression-free survival compared to those patients who received obinutuzumab and chlorambucil. And again, you can see that these curves go out to 3.5 years, and they separate. And so the red curve is clearly below the blue and the gray curves. And that's, again, why we feel that acalabrutinib is a superior option compared to chlorambucil in those patients that have untreated CLL. And then in addition to the BTK inhibitors, Venetoclax is another therapy that's currently available for patients with CLL. Venetoclax targets something called BCL2, which we think is an important activated protein in patients that have CLL. And this, again, was a study of patients with untreated CLL that were either older or had medical comorbidities. So you can see a similar group of patients. And these patients received either obinutuzumab and chlorambucil or obinutuzumab plus venetoclax. And one of the things that was particularly interesting about this study is that instead of being administered indefinitely, in this case, the therapy is administered for about a year. And so it's a more time-limited therapy. And just like what we saw with those prior curves, the venetoclax, which is the solid line, the solid black line, that group outperformed those patients who received obinutuzumab and chlorambucil. And so based on these really 4 studies, the 2 ibrutinib trials, that acalabrutinib trial I just showed you, and this venetoclax study, there's now several studies that have suggested that either a BTK inhibitor or venetoclax are superior to more traditional chemotherapy-based initial therapy regimens. And in addition, ibrutinib and other oral agents are effective in relapsed CLL. So there may be some of you on the call that received chemotherapy several years ago before these clinical trials came out, and perhaps your disease is coming back now, or it may come back in the future. And I think it's important to recognize that these agents are also very effective in the relapse setting. So ibrutinib is administered once daily, similarly to the upfront setting. And you can see here that the progression-free survival on this curve is superior compared to those patients who received ofatumumab, which is another antibody that targets CD20. And you can see that half of the patients hadn't progressed at the 4-year mark. And so while this curve isn't quite as flat as the ones we saw in the front line, it certainly suggests that ibrutinib is a very, very effective therapy in patients who have relapsed CLL. And similarly, acalabrutinib is also very effective. And so this is administered twice daily. Actually, I do need to, this has now actually is currently FDA approved for this indication. This is a typo here, but so acalabrutinib is also an option in the relapse setting. Now, many of you may be wondering, well, we know that ibrutinib is effective, we know that acalabrutinib is effective, we know that venetoclax is effective, so maybe we should combine these and see if we can improve outcomes. And this actually has been done on a number of studies. This is one such trial that was published a couple of years ago and then recently updated by the group at MD Anderson, and patients received ibrutinib in combination with venetoclax. And one of the things I want to point out, if you look at the bar graph on the left, the gold bars are the percentage of patients that have what we call an undetectable MRD in the bone marrow. And what that means is that when those patients have a bone marrow biopsy performed while on treatment, that not only do they not see CLL in the bone marrow, but even using very specialized tests, they can't even detect any CLL cells. And so we know that having undetectable MRD is something that likely is important for predicting how long patients are going to stay in remission. And so one of the things about this study that's particularly exciting is that after about 18 months of therapy, you can see that over 2/3 of patients with this combination have undetectable minimal residual disease in the bone marrow. And when they recently updated the study at ASH, at our most recent annual meeting, you can see, number one, that the progression-free survival for both IGHV mutated and IGHV unmutated patients, which are the two main groups of patients we see, was quite good. You can see that both of these curves stay pretty close to 100%. And perhaps even more exciting, if you look to the right, you see that there are a number of curves here, and these represent different groups of patients that have different prognostic features when we look at their chromosomes, at their genetics. And some of these are traditionally high-risk features, and even amongst those patients with high-risk features, this combination was quite effective. And so while this is not necessarily utilized outside of the setting of a clinical trial yet, I do think that this combination is a very effective combination in patients with CLL especially, and it'll be interesting to see if that ultimately does become part of our more standard approach. Now, as I mentioned previously at the beginning, there are some toxicities associated with all of these therapies. And so BTK inhibitors are associated with bleeding and bruising, fatigue. There can be other atrial fibrillation and other heart rhythm abnormalities, and you can see several others that I commented on. And I think it's important to recognize that toxicities can be different between these agents. And so so acalabrutinib, for example, is associated with a little bit more of an increased rate of headache, but a little bit lower rate of some of these other agents. There's another therapy called zanubrutinib, which has been approved for mantle cell lymphoma, which looks to have a little bit of a different toxicity profile, perhaps a little bit more issues with blood counts, but less issues with atrial fibrillation or with bleeding. And so it's important to have a conversation with your doctor about which BTK inhibitor is most appropriate for you based on your own situation. Venetoclax is typically well tolerated, but can be associated with something called tumor lysis syndrome. And this is a condition where the tumor breaks down as you start the therapy. And although this is a good thing, when that happens quickly, different toxins can be released, including uric acid and potassium and other electrolytes, and this can cause kidney damage. And so this is manageable, this is preventable, but it just requires close collaboration with your oncologist. And so some of our patients actually have to be hospitalized to initiate therapy and to get IV hydration. And generally, all patients complete a ramp up during the first month of treatment. And so when I'm counseling patients, I often will tell them that they have to be flexible with their appointments and scheduling, especially during that first month. And that at the first month especially, there's a high hassle factor. And so if it's somebody that can't get off work or that can't get back and forth to the clinic for lab draws, this may or may not be the best option for them. But the good news is that this is usually something that occurs during the first few weeks of treatment. And once you get through that first month and you get ramped up, the tumor lysis syndrome typically won't happen at that point. So it's really something that we have to address during that first month. And there's a number of ways that we do that. And then for Venetoclax, otherwise, there can be some GI side effects. There can be some low blood count issues, but most patients, once they get through that first 4 to 6 weeks, generally do pretty well. Another class of agents that we look at are the PI3 kinase inhibitors. These are approved in a number of different lymphoma subtypes, including follicular lymphoma and CLL, and now marginal zone lymphoma with this most recent approval of umbralisib. And it's important to recognize that just like with the BTK inhibitors, toxicity can be variable amongst these different agents. There are some rare but potentially serious side effects with PI3 kinase inhibitors. So CMV and pneumocystis pneumonia are both unusual infections, but ones that have been seen with these agents. These, again, are rare and can be monitored for, but it's just important to be aware. There can also be immune-mediated toxicities, including colitis. And colitis can be particularly challenging. So this is where patients develop significant diarrhea and abdominal pain. And one of the challenges with this particular toxicity is that it often develops a year to 18 months into treatment. And so you may be on therapy, you may be feeling well, sort of on cruise control, so to speak, and then all of a sudden, 13 months in, develop some diarrhea. And it's important that patients are aware that this is something that can develop. It's something that can be reversed. It's something that can be treated, but it's just important to be aware of it. And then you can see also there can be lung and liver toxicities as well as rash. And then some of these have some more specific toxicities associated with them, including high blood pressure and hyperglycemia or high blood glucose. And again, this is where it's very important to have a conversation with your doctor and where you really consider your own medical situation. So for example, if you have diabetes, it may be that one of these isn't as appropriate as the other one. It doesn't mean that you can't be on one of these agents and that you can't do well, but it's just important to take these things into account. So this is sort of my CLL approach. And again, the main reason I have this here is just to highlight oral therapies have significantly changed the way we think about managing patients with CLL as well as other diseases. And so typically I'll do a prognostic evaluation, including the IGHV mutation status and FISH. And then there are some patients that are IGHV mutated and young and healthy that don't have high-risk cytogenetics, and those are patients that we still sometimes think about for chemotherapy. But you can see that if you look at the whole rest of the slide, pretty much everyone else, I'm looking at an oral agent, and typically a BTK inhibitor or Venetoclax, plus or minus a CD20 antibody like obinutuzumab. And so I think it's, again, very important to recognize that most people are now receiving oral agents for their CLL or SLL. And again, I want to highlight the importance of always considering clinical trial enrollment because we certainly don't know all the answers. And one such study that I just want to put in a plug for is this trial that is being run through the U.S. Intergroup. So this is sponsored by the National Cancer Institute and is open nationwide. And this is looking at the combination of obinutuzumab and ibrutinib administered indefinitely versus obinutuzumab, ibrutinib, and Venetoclax. And so what we're really trying to find out is, can you give these three drugs all together? And if you give them all together, can you give them for 18 months and patients do just as well as if they were on obinutuzumab and ibrutinib indefinitely? This study is open at my own center. I've treated several patients on the study, and they've generally done quite well. And so I would encourage you to, if you're at a point where you're having to think about treatment, your first treatment for CLL, to consider this study if it's available to you. I'll talk briefly about oral therapies and some of the other disease subtypes, and the reason it's a little bit briefer is just because we're not using them quite as frequently or quite as ubiquitously as we are with CLL. So in follicular lymphoma, we often consider the role of lenalidomide. This is an immunomodulatory agent, so what we think is that it helps to rev up your immune system to fight the cancer. And so there was a study that was presented, I guess now 2 years ago, called the Relevance trial, that compared rituximab plus chemotherapy versus rituximab plus lenalidomide in patients with untreated follicular lymphoma. And you can see here, as opposed to the other curves that I showed you before, that these two curves pretty much overlap. And what that means is that there was no significant difference, no improvement of doing lenalidomide as opposed to chemotherapy. Now, the other way to look at this, though, is that we think from this we find that lenalidomide is a very effective agent in patients with follicular lymphoma. So if you are not a candidate for chemotherapy or not interested in chemotherapy, there's potentially still a role here for rituximab and lenalidomide, which would be a chemo-free approach. And then lenalidomide is also effective in the relapsed refractory setting. And so here you can see that rituximab plus lenalidomide was compared to rituximab plus placebo, or basically rituximab by itself. And you can see here that the curves do separate and that the lenalidomide-containing arm was better than rituximab alone. And so for my own patients, I often do consider lenalidomide if they have relapsed follicular lymphoma. Now, just like the other agents, there are some side effects to keep in mind. So lenalidomide is associated with thromboembolic disease or blood clots. And so it's important that you have a discussion with your oncologist about the need for an antiplatelet agent like aspirin or perhaps a blood thinner. And this often has to do with your other medical comorbidities, maybe a history of blood clot and so forth. It can be associated with birth defects. And so anybody that goes on lenalidomide has to complete a comprehensive counseling program to make sure that they manage it properly and keep the drug away from women that may be of childbearing potential. And then there can be fatigue, rash, low blood counts. And so these are patients, like any patient that's on an oral agent, that needs to be followed closely, and we often have to consider dose adjustments based on how they're doing on the treatment. In addition, the PI3 kinase inhibitors are also very effective in this setting, and I have several patients that are currently receiving PI3 kinase inhibitors and doing fantastic. So we have 3 oral options now for relapsed refractory follicular lymphoma, and then we also have an IV option. And sometimes I have, when I've had this conversation with patients, they'll say, well, why would I do an IV if I can do a pill? And sometimes it's an issue where those patients have difficulty sort of with taking pills every day. They may have difficulty obtaining it because of their prescription coverage. There also are some differences in toxicity. And so it's nice that we at least have both options if you think that a PI3 kinase inhibitor is a good option. These therapies, though, are quite toxic when combined with chemotherapy in the untreated patients. And so I would not recommend that they be used in that setting. There were a number of clinical trials that ultimately had to be discontinued because of some toxicities that were seen. But in the relapsed refractory setting, when used sort of as labeled, as indicated, this is also a very effective therapeutic class. And so in addition to the trial I highlighted in CLL, there's also studies using oral agents in follicular lymphoma. And this is a study that's particularly of interest to those patients who progress within 2 years after receiving their initial treatment for follicular lymphoma. In this study, patients are randomized to receive either more chemotherapy, obinutuzumab plus lenalidomide, or obinutuzumab plus TGR-1202, which is now UMBRA-listed and has now been approved. And so basically it's looking at a PI3 kinase inhibitor, lenalidomide, or traditional chemotherapy to see which is better for patients that present with early relapsing follicular lymphoma. And then in mantle cell lymphoma, we also have several options. There are 3 approved BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib. And just like with the PI3 kinase inhibitors, and as I mentioned before, there can be some differences in side effect profile among these 3. And so I think it's very important to have a discussion with your doctor about which one is most appropriate. I would say that they all seem to be very similar with regards to how well they work. So I don't think anyone is necessarily, quote, better than the other one. I think, again, for individual patients, there may be a reason that one is better for you. In addition, Venetoclax has been shown to have some promising efficacy alone and in combination with ibrutinib, and there's a number of studies looking at this. Lenalidomide is also effective, usually given with rituximab in the upfront or in the relapse setting. And then just like I mentioned in CLL and just recently with follicular lymphoma, there are a number of combinations that are currently being evaluated. So Venetoclax, ixazomib is an oral proteasome inhibitor, palbociclib is something called a CDK inhibitor. Again, it's not critical to know the ins and outs of each individual therapy other than to recognize that there are a number of oral agents and that these are being evaluated in a number of different combinations to hopefully improve outcomes for patients with mantle cell and with all lymphomas. Compared to CLL, the oral agents in mantle cell aren't typically associated with quite as durable a remission. So if I have a patient that's going on acalabrutinib or ibrutinib for relapsed mantle cell lymphoma, my hope is that they're going to do well for a while, but I usually will start to counsel them about the fact that Their remission may not be quite as long as we would have hoped if they had CLL, and so we start to think about what else may be out there for them. And so far, BTK inhibitors in the front line have not been shown to improve outcomes, but there are a number of studies that are underway that are evaluating this, and so this certainly may change in the near future. But right now, most of these agents are being used in the relapse setting outside of the setting of a clinical trial. And then for large cell lymphoma, I think there needs to be some caution. So whereas for CLL and follicular lymphoma and other indolent lymphomas and for mantle cell lymphoma, the oral therapies have really taken hold. In large cell lymphoma, the oral therapies are a little bit less promising, unfortunately. And so, for example, R-CHOP is our most traditional regimen that we use, and there's been a number of agents that have been added to R-CHOP, and so far we haven't seen any that have definitively improved upon R-CHOP by itself. In the relapse setting, there are a number of agents that we can think about, including lenalidomide and selinexor, as I commented before. But for the most part, if you're thinking about an oral agent for large cell lymphoma, I would think about that in the setting of a clinical trial. Again, with the few exceptions I mentioned, especially in the relapse setting. But often these are agents that are incorporated as part of clinical trials because for the most part, especially in the upfront setting, they haven't necessarily emerged as a definitive better option. So here in these last couple minutes, I'm just gonna highlight a few general talking points, and then I'll be happy to take some questions. So I think it is very important that you discuss the goals of any treatment that you're going to be taking prior to starting it. And I think this is particularly important for patients that are going to be receiving oral agents. And the reason is that if you're going to commit to being on therapy for a year, for 18 months, for forever, indefinitely, that you want to know sort of how will you know it's working? So are you going to be getting scans? Is it going to be based on blood work? How are you and your doctor going to know that it's working? You know, so often I'll tell my patients, you know, what does success look like for us? When will you stop the treatment? And so it may be that there's no planned stopping point, but I think it's always a good idea to have a sense of what you're getting yourself into. And then do the requirements of the treatment fit your goals and your lifestyle? So if you are somebody that has options, and for you, the possibility of being admitted to the hospital on a weekly basis for a couple of weeks or having to come in to get labs once or twice a week is not something that's going to work for you, then venetoclax may not be the best option right now. You may want to look at other options. Similarly, if you are somebody that it's important to you to engage in, you know, somewhat dangerous activities like skiing on really steep slopes or something else where there's a not insignificant likelihood of an accident or some sort of a trauma, then maybe Ibrutinib isn't the best option for you because of its bleeding risk. So I think it's just important to make sure that you have this conversation up front with your doctor. It's also important to recognize that oral therapy has really changed our thoughts about side effects and toxicity in general. So it used to be if you were on chemotherapy, you came in for your treatment, we asked you how you've done, we checked your labs, and if everything went well, you got your next treatment. But now many patients are coming in once every 3 months. So we're not seeing them as frequently. They may have side effects that are not particularly major, but which can be annoying over time. And so it's important to continue to communicate with your team about side effects. And we really are still learning about some of the longer term side effects. More is not always better. So I often have patients ask me, well, you know, why are you only putting me on one therapy? If you think that there's 2 effective drugs, why don't we combine them? And so far, we don't know for sure that 2 drugs or 3 drugs for that matter are going to improve the overall outcome. So this is why we have a number of studies ongoing that are designed to try to answer these questions. But it may be that if I were seeing you in clinic right now and outside of the setting of a study, that just doing a single agent drug is probably is just as effective. And so again, you want to consider the goals of treatment, look for opportunities to discontinue therapy, and so it may be that continuing therapy indefinitely for a particular agent for a particular patient isn't right. And again, and what I often tell folks is that sequential approach may also be equivalent. So for example, a patient may do just as well receiving one therapy followed by another than they would have if they received both therapies together. We just don't know yet which one is the best way to manage that situation. And then it's very, very important to communicate clearly with your team about the cost of therapy and your out-of-pocket costs. These are therapies that must be taken regularly and must be taken on schedule. And so it's very important that you communicate if you can't maintain that schedule or if you're having an issue with cost, because as I mentioned before, there are things your oncologists can likely do to work with you to try to help obtain these therapies at a reasonable cost. But the one thing that you don't want to do is start and then have to skip doses or skip a month or come off unexpectedly because of cost or because the schedule is just isn't something that you can work with. And so it's not to say that we can't make those changes down the road, but the worst thing to do is to recognize that there may be a problem and not speak up, and then all of a sudden something comes up as you get started. So please communicate clearly with your team, because if you let us know what's going on, we can almost always work something out for you. And so as I finish up, just some future directions to think about. So there are a number of studies underway to evaluate time-limited treatment. So as I mentioned at the very beginning, going through training, there was always this hope that we would get to where, a patient would have a particular type of cancer, they would get prescribed a pill, and that would take care of it. And in some ways, we've gotten to that point. But for many of my patients, the idea of being on therapy indefinitely is very challenging, especially, maybe if you're a little bit younger and you're looking at 25, 30 years of being on therapy, that's can be daunting. And so there are a number of studies underway looking at time-limited treatment. I think there's also going to be further study of chemotherapy plus oral agents, especially in the aggressive lymphomas, where we think chemotherapy is still an important aspect of treatment, but where it's possible that adding an oral agent may help. One thing that I didn't really get into in this talk, but is that there are a number of molecular assessments that are ongoing. And what I mean by this is looking for specific mutations, specific features of your cancer that may predict whether or not you're going to respond to a particular therapy. So for example, the EZH2 inhibitor, tazemetostat, while it may be effective across all patients with follicular lymphoma, appears to be particularly effective in those patients that have an EZH2 mutation. And this is something that we can test for. And so this is something that's becoming more and more prevalent across lymphoma subtypes and in lymphoma clinics as we learn more about this. And then finally, one last plug, just to please consider enrolling in a clinical trial when you have that opportunity. There are a number of very exciting new therapies that are in development, and this is one of the best ways to have access to those therapies. Many of my patients have done fantastic enrolling in clinical trials. And just to allay any fears, these studies require close collaboration with the FDA, with regulatory bodies, and so forth. And so, as I often tell my patients, this is not something that I just come up with in the hallway before I come in to see you. These projects take many months to put together, and a number of folks are involved. So I find them to be very safe, and would be happy to have my family participate in a clinical trial if one was appropriate. So with that, I'm going to finish, and I want to thank again the LRF. I can't say enough about how much they do for patients and for lymphoma investigators nationwide, and so I do recommend that you check out the resources when you have a minute, and otherwise I'll turn it back to Jesse, and I'm happy to take any questions. Thanks again.
Great. Thank you so much, Dr. Cohen, for that really wonderful overview. And we'll now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible so that the entire audience can benefit from their answers. If you'd like to ask a question, please submit your question through the Q&A box on your screen. We'll take as many questions as possible, but if you have a question that does not get answered, you can always reach out to the LRF helpline at 800-500-9976. And our first question is coming from online from James from Minnesota, who's listening in. And he says, I am on acalabrutinib for mantle cell lymphoma after 3 relapses. Is this common? Can you comment on this or other potential options?
Yeah, so thanks, James. And I have to say, I'm here in Atlanta. It's about 70 degrees and sunny, but I hear that the upper Midwest is particularly cold this week. So hope you're staying warm. So acalabrutinib is a very effective therapy for patients with relapsed mantle cell lymphoma. And so especially in somebody that may have had the disease for a long time, that or maybe it wasn't available in the past, it is common for folks to be on that type of therapy. As I mentioned, one of the challenges with the BTK inhibitors in mantle cell lymphoma, as opposed to CLL, is that the remission duration is not quite as long. And so I don't know how long you've been on treatment, but I do think it's worth having a conversation with your doctor about what the next step may be when the acalabrutinib stops working. And I have some patients that have been on it for many years, but I think it's important to be prepared One of the things that may be an option for you are CAR T-cell therapies. This has recently been approved. There's I'm not sure where you are in Minnesota, but there are several programs up there that have access to these cell therapies. So I think the key, I think it's in most cases, it's one of the best therapies you can be on, but I think it's always good to be thinking ahead about next steps.
Great, thank you. Our next question comes from Bob, who asks, thank you for providing this. Do insurance companies bill oral therapies as outpatient treatment or a prescription?
So excellent question, and I think this is actually important for everyone to recognize. And so, the one disclaimer is that I am a trained lymphoma physician, but sadly, we get fairly limited training in some of the business aspects of medicine. But what I can say is that almost always the oral agents are billed through your prescription plan, and this is where we sometimes run into some challenges. So an outpatient infusion or an outpatient therapy often goes through your more general medical plan. And so that's where, as I mentioned before, if we think that copanlisib a PI3 kinase inhibitor is a good option for you, but maybe you have limitations with regards to your prescription coverage, an IV infusion may be more financially feasible for that particular patient. And so these are, we often want to be thinking only about the medical aspect, but it's important to keep these practical considerations in mind. So, but to answer your question, it typically does go through your prescription coverage.
Great. Thanks, Dr. Cohen, for clarifying that. Our next question comes from Gary, who's in California, and he asks, for oral therapies that use combinations such as Venetoclax plus obinutuzumab plus zanubrutinib, do the general cons or side effects you mentioned get worse or reduced?
So it's a good question. The short answer is we don't know, and that's why a number of these clinical trials are being done. In general, we have seen that at least the BTK inhibitors can be safely combined with Venetoclax. That's been done in a number of different settings across a number of disease types, and so that is a relatively safe combination based on the data that we have. It certainly is still important to monitor for side effects. There are other combinations that have proven to not be safe, and so again, it's important to either, if you're going to be on a combination, to either do so in the setting of a clinical trial or to use a combination that has sort of been based on clinical trials that have been previously published, and not necessarily just sort of a random combination, because it just depends.
Our next question is from Eva, who asks, in treatment-naive CLL patients needing to start treatment, would you favor one BTK inhibitor over another?
So this is a very challenging question. So I would say the short answer is no, and the reason I say that is because I really do think that's an individual conversation for a patient. So so on its face, it does appear that there may be some decreased toxicity with acalabrutinib, although it's important to recognize that acalabrutinib has not been compared head-to-head with ibrutinib in a randomized trial. But having said that, there are some therapies, so acalabrutinib has to be given twice daily, and also it typically cannot be administered with a proton pump inhibitor like Nexium or Prilosec. And so there are pros and cons to each of those. So the short answer I would say is no. I think that's where it really is important to have a conversation with your treating doctor, taking into account your own situation and what makes the most sense for you.
Thanks, Dr. Cohen. And our next question is Paige, who's listening in from Massachusetts, who asks, you mentioned 2 new oral therapies for follicular lymphoma. One was tazemetostat. Can you remind me of the other and share more information about them as options for follicular lymphoma?
Sure. So I suspect, Paige, that you're referring to umbralisib, and this was literally just approved last Friday. So if we had scheduled this a week ago, it would not have been approved. And umbralisib is a PI3 kinase inhibitor, so it's from the same class as idelalisib and duvelisib. And we don't have to get into all the specifics, but each of them, as I mentioned, function in a little bit of a different way in that they target different isoforms of PI3 kinase. Umbralisib does appear, again, to have a little bit of a lighter toxicity profile than some of the others. But as I mentioned before with the BTK inhibitors, is we don't necessarily have a lot of head-to-head data to go on. But I have several patients in my own practice that we have treated with it on clinical trials, and they've done very well with it. So I think it's a very effective therapy, and it's great to have it as another option.
Great, thanks, Dr. Cohen. Our next question comes from Margaret from Virginia, who asks, in regards to treatments such as BTKs, is it common to provide a dose reduction and increase that dose with time for patients with drug sensitivities?
So, Margaret, I know it's a little bit different because we're not sort of talking face to face. So, the first thing I would say is that I think this is where you really do need to talk with your doctor. I'm assuming you're asking if you're worried a patient may have a drug sensitivity, would you start them at a lower dose and then potentially increase the dose? This is certainly something that could be done. It's not generally my practice. I found that often patients are able, even those that have had some sensitivity to other agents, are able to tolerate the full dose. But one of the things that we have seen is that if a patient is unable to tolerate the full dose, that decreasing the dose doesn't appear to significantly impact their outcome. Although, again, that's, we don't have definitive data suggesting that, but I certainly, at least in my own practice, feel comfortable that if somebody is responding, meaning their disease is responding, but they're having a side effect, that I would consider lowering the dose. But in general, unless there aren't some other therapy that I think is going to interact, like another medication, I usually will start patients at the full dose, with few exceptions.
Great, thank you. We have time for a couple more questions. Judy from Pennsylvania asks, how do you feel about taking 325 milligrams of aspirin daily on Ibrutinib? Does it increase bleeding possibilities, and is there any hope that it could be used for a short time instead of forever?
Okay, so again, good question. So I know I sound like a broken record. I think it really comes down to sort of your own situation and risk. So as a rule, if I'm okay with somebody being on aspirin, even if it's 325 milligrams concurrently with Ibrutinib. I think what's important, though, to keep in mind is that is what all is going on sort of for that patient. So if it's somebody that may be frail or prone to falls, I'm going to be a little bit more concerned about them being on aspirin at the same time that they're on the Ibrutinib. On the other hand, if it's somebody that's very active and I'm not as worried about falls or things like that, I would typically be more comfortable with them being on aspirin. And the same actually goes for anticoagulation like Eliquis, those types of therapies. I have a similar sort of risk-benefit discussion with the patient. With regards to being able to stop it, so there are some emerging data from at least from CLL, that amongst those patients who received rituximab and Ibrutinib on the ECOG trial, one of the ones that I presented, that had to stop therapy, that a significant portion of those patients have remained in remission. So maybe they came off due to a side effect or for whatever reason. At least some of those are a couple of years out and still in remission. And so I do think for some patients, there's likely a group of patients that could potentially discontinue the Ibrutinib and stay in remission for a while. The challenge we have is that at least right now on February 10th, 2021, is we don't have a reliable way of identifying who those patients are in a way that would make me feel comfortable stopping it. So today, outside of the setting of a study, I wouldn't stop it unless I needed to, unless somebody was progressing or was having a complication. But talk to me in a year or two and we may have more evidence to suggest that at least some patients can stop.
Thanks, Dr. Cohen. And then we have our last question of the day. This one might be difficult because I'm not sure about the data we have, but Rebecca from New Jersey asks, do any oral therapies at this time seem to have worse outcomes for patients seeking the COVID vaccine?
Great question. So to my knowledge, the answer is no. So I guess if it's okay, I can talk briefly about sort of how I've been thinking about COVID in general. And so what I've been telling for my patients that are on chronic oral therapies, I've been comfortable with them receiving the COVID vaccine. There has not necessarily been clear evidence that they are going to be at any increased risk as a result of getting the vaccine. What we don't know is how effective the vaccine is for that patient as opposed to a person that's not on on an oral therapy. And the same goes for chemo or for rituximab. So patients that might be on rituximab maintenance, for example, can likely safely get the vaccine, but we don't necessarily know how well it's going to work. So what I've been doing is if a patient is not on treatment and is stable, I've been having them get the vaccine as soon as they can, and with the hope of being able to have it take effect before they have to start therapy. If, however, somebody's already on treatment, my feeling is some protection is better than none, and so I've been recommending that those patients go ahead and get their vaccine, including those that are on oral agents. And I'm also recommending that when their turn comes up, that their family members that are near them or that are around them also get vaccinated, just to provide some additional protection.
Great. Well, thank you so much, Dr. Cohen, for joining us today and sharing your expertise on this topic. I know everyone on the call really appreciated you taking time out of your busy day to talk with us on this very important topic, so we really appreciate it. And thank you again to everyone for joining us on today's call, and we hope you found the information both informative and also hopeful. We'd also like to thank our sponsors again for making this program possible, Karyopharm Therapeutics and Pharmacyclics and AbbVie Company and Janssen Biotech. Please remember, if you have any additional questions or you'd like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I'd ask that you please take a few moments to complete this brief evaluation, as these are important for helping LRF to ensure that we deliver the most useful and meaningful programming to you. And with that, I'd like to thank you all again for joining us and hope you have a wonderful day.